It's now time for our clinical topic, and I have the pleasure of introducing our speaker today, who's Dr. Bart Silverman. He received his dental degree from Fairleigh Dickinson University. He completed his oral and maxillofacial residency at Westchester County Medical Center, and he maintains a private practice in New City, New York, and is a diplomat of the American Board of Oral and Maxillofacial Surgery and a diplomat of the American Board of Oral Implantology. You know, he's been lecturing the field of implant dentistry for over 25 years. Dr. Silverman is an attending physician at Westchester County Medical Center, a clinical associate professor at New York Medical College, and he's also the director of the AAID Maxi course in Salt Lake City. And he's also my friend. His topic today is one of great interest, and I'm looking forward to hearing him complete part 2 of his lecture that he provided part 1 a month or so ago. It's called A Step-by-Step Approach to Treating Dental Implant Complications. Bart, all yours.
Thank you very much, David. That was so nice. That was such a nice introduction, probably one of the most eloquent ones I had. So thank you so much. I am truly honored to be back for part 2. Really honored to be asked back for the Glidewell Study Club. This is such a great situation that you guys have provided. I know you started around COVID time, and I think we were talking beforehand. This is about the 3rd year or so into our 3rd year about doing this. So really honored to be here. And also a special thank you to Nicole for all your help in setting this all up again for part 2. Okay, so as David said, what we'll do is we'll go through some more stuff about our step-by-step approach to treating dental implant complications. And then what we'll do is we'll set aside some time for some questions and answers at the end. Also, so David already explained, board certified oral and maxillofacial surgeon, dual boarded in oral implantology as well. Just lecture a lot around nationally, internationally, just really love sharing information, and it's just a lot of fun. And at the bottom there, that's my Instagram handle, so BWS Oral Surgery. And if I don't follow you already, please follow me today and I'll follow you back by tonight. And I think that this is the best way for all of us to exchange information and really learn from each other. And it makes it more fun. All right, so I have to say that the opinions in this lecture are my own, and none of the way have the images been altered or manipulated. And if you see any company slides here in the presentation, they're there because I chose to do them. And of course, we need to say this because it's a CE event, and I'm being paid an honorarium for this program, I hope. And I do consult for several companies. So just to review what we talked about last time is that the potential complications for potential causes for dental implant complications center around these 4 factors that influence our treatment option. So there's the patient who presents to us with their dental and medical risks, their anatomical risks. It's the characteristics of the biomaterials that we have available to us. It's the treatment approach that we need to think about, the degree of difficulty, the documented risk, and it's us as clinicians, our experience, skills, and judgment. And it's funny because the common thread to all 4 of these little aspects and spokes of the wheel, so to speak, is us as clinicians. And what we need to do is we need to examine our patients, and we need to perform a detailed risk assessment of our patient who is about to undergo surgery and determine their suitability to undergo that surgery. And that's number 1. Number 2 is it's us also as clinicians that we have to select the appropriate biomaterials that we use, the implants we use, the bone grafts we use, and the barrier materials that we need as well. And then lastly, we need to select the proper treatment approach that gives us hopefully provides us the most successful outcome with the highest degree of predictability and the lowest risk of complications. And now we need to carry out those treatments that we decide to do, or we need to enlist the help of a colleague or another specialist to help us out. But all in all, we need to manage and be able to diagnose complications. And of course, you can't manage every single complication that comes into your practice, but you really need to know how to diagnose the problems and then to assess the situation and then determine who needs to help treat that particular patient. So the objective so far for our particular seminar is that what we wanted to do is discuss implant complications as they occur in 2 timeframes, early and late. Last time we kind of focused on the early complications. This time we're going to focus on more about the late complications. We're also going to discuss every single complication we talk about is that the best way to treat complications is through prevention. And then if we do see a complication, or if we do get a complication, whether it's related to surgical or prosthetic, it's okay. It's okay. and we need to know how we treat them. All right, so this was on last night. I saw this on the news. Actually, this is on Jimmy Fallon last night. So this particular person was talking, newscaster was talking about this great snowstorm that came in, and now the snowboarders are coming out, and everybody's around there. And look, what are the odds that that can happen? That there's a whole big mountain, a whole big hill, and he gets hit by that one snowboarder. So it just reinforces that anything can happen at any time, and you need to be prepared to know what can happen, and complications can occur at any time. And most importantly, we need to know who to handle, who to call to help us handle a situation if you can't handle them. And most importantly, what we need to do is you need to have the tools and the armamentarium in place to be able to handle some complications. You need to approach the situation in the right fashion. This particular person coming down the icy hill with some heels, it probably doesn't look like the best way to approach implant dentistry, so to speak. Okay, cool. And she made it. Very good. Okay, so there's a whole bunch of complications. And of course, the more we practice, the more implants that we place, the more complications that we'll see. The more implants that are placed by our colleagues, the more complications that we'll see. And there's a whole bunch of stuff out there. Okay, so just like last time, let's get started. And hopefully what we can do is we can avoid that downward spiral. Okay, so as we said, the mantra today is going to be the best way to treat our complications is through prevention. Okay, the best way to do is let's avoid if we can, and then we don't have to worry about treating. Okay, now, if we do have a complication, we need to know how to diagnose that complication. What happened? Why did it happen? And how can it be prevented? And I think that's important too. We need to learn from our mistakes. We need to determine what's the etiology of this particular complication, and then we must be able to treat that etiology of that complication. Okay, and we said last time too, it all starts with good medical history, good diagnosis, a good case workup, and a good treatment plan. And what we talk about, what I talk about all the time is I'd like everybody when they approach our cases, whether it's implant related or not, is to go through a methodical approach as we approach our particular patients, obtain a good medical history, a good clinical examination, a good radiographic examination, overall determine the complexity of the case, determine a treatment plan, get some informed consent, and then determine how you're going to do this procedure through local anesthesia or conscious sedation. And more importantly, what I like you to do is take all this information and to develop 4 treatment plans. Every single case, if you can develop 4 treatment plans, it will keep you out of harm's way. So look at each particular situation, develop a non-implant related removable option, if possible, a non-implant related fixed option, an implant related removable option, whether it's an implant retained dual supported case or a complete implant supported overdenture, and then implant supported fixed options, whether it's fixed, hybrid, or full arch, or fixed crown and bridge. And then take these 4 particular treatment plans and determine that one particular treatment plan that's best for that patient. And we feel that if you approach all your implant cases in this fashion, it will set you up for success. Okay, so last time we talked about early complications. We said that's any complication that occurs before an implant osseum integrates. Before the implant fuses to the bone, something occurs. This would be an early complication. In the same token is that a late complication will be any complication that occurs after the implant fuses to the bone and the prosthesis is placed. Now, if we look at late complications, we can divide them up into biologic as well as mechanical. Let's start with biologic. Here, the peri-implant hard and soft tissues are affected. In 1993, there was the first European workshop on periodontology, and what they got together, they looked at mucositis and peri-implantitis, and they determined that there was a cause and effect relationship between bacterial biofilm accumulation and the inflammatory tissue alterations and responses we were seeing. I guess they had such a good time, they decided to reconvene again in 2017, where AAP got together with the European Federation of Periodontology, and they decided to determine a classification for periodontal and, more importantly, peri-implant diseases. And of course, a classification was necessary because based upon what is normal, we can then classify what is abnormal, and then we could also get into treatment approaches based upon the classification. So they determined that peri-implant health was a tissue that was around an implant that was showed an absence of erythema, bleeding upon probing, swelling, and separation. Now, if they determined peri-implant health, then we started to get into what was called abnormalities or peri-implant mucositis. Now, peri-implant mucositis is when the patient presents to us when they show bleeding upon probing, redness of the tissues, swelling, and or sometimes separation around these particular tissues which surround the implants. Okay, that would be peri-implant mucositis. Peri-implantitis, this was determined to be a dental biofilm-associated inflammatory condition and was characterized by inflammation in the peri-implant mucosa. So if there was presence upon bleeding of separation with gentle probing, increased probing depths compared to previous examinations, and presence of bone loss beyond crestal level changes resulting from the initial remodeling. Now, the interesting thing is this last statement kind of requires observations from a baseline. So of course, if the patient is a patient of record, we have previous examinations that we can refer to. But if a patient is a new patient to the practice, they needed a definition to go along with that. And then they determined that peri-implantitis would be the presence of bleeding and or separation with gentle probing depths of greater than 6 millimeters, and bone levels of greater than 3 millimeters apical to the most coronal portion of the intraosseous part of the implant. Okay, so if we look at this now, we'll be able to determine if any patient who comes into our practice was diagnosed with peri-implantitis. Okay, overall, if you look at overall dental implant complications on implants that are replaced, you can see that the prevalence of peri-implant mucositis and peri-implantitis ranged anywhere from 20 to 65% in the literature. Mucositis, as we said, you kind of look at that. This is almost like implant gingivitis. And over any 10-year period in the life of an implant, 70% of the implants that are placed exhibit a form of mucositis during that particular time frame. And once again, just to summarize, these are the implants and the tissues that present to us around the implants that show erythema, some swelling, no real probing depths. We can have pseudopocket depths that we get when we see inflamed tissue around the implants, just gingival hypertrophy. Sometimes we get bleeding upon probing, but no bone loss. Okay, what's the treatment now for peri-implant mucositis? We recommend curettage. You can use some scalers, some titanium scalers, carbon scalers, irrigation with Paradex. Now, this is a little controversial. Paradex actually works in the sense that it's bactericidal as well as bacteriostatic. But in some of the recent literature, it shows that it tends to kill fibroblasts, but most of us practitioners still will irrigate with Paradex. And then we reevaluate our patient at a 3-month recall. If they present and the situation is about the same, maybe slightly worse, we recommend, once again, curating around the implants. Sometimes here, maybe we remove the appliance itself, remove the crown on top of it and curette around the lower part of the implant. Once again, irrigation with Paradex or maybe 0.25% sodium hypochlorite. In this particular situation, we might consider intrasulcular antibiotics. We reevaluate again in 3 or 4 weeks, and antibiotic only if we have abscess. Okay, once again, the key here is prevention. So when we make our restorative cases here, let's place our restorative margins supragingival if we can. Of course, on the buccal, we can't when it's cosmetic, but on the palatal, in brazier areas, we sure can. Let's provide good access for our patients for oral hygiene. Okay, very, very important. Let's set them up with a good oral hygiene and plaque control situation as well. Most importantly, good preoperative planning. Surgical placement and technique is paramount, and the use of implants with good macro and micro designs, very, very important. And we also need to establish an adequate level of attached gingiva. This has been very, very important. Then the question comes up, how much is enough attached gingiva? What's our minimum amount of attached gingiva? Well, we found Adebrad did a study, and he said that if you had equal of 2 millimeters or more of attached tissue, or keratinized tissue, that you're going to see less mucosal recession. Also following up on that particular study, it showed that if you didn't have that amount of keratinized tissue, those particular cases would be the ones that were going to come back to us with higher plaque accumulation, more gingival inflammation, bleeding upon probing, and also mucosal recession. So how do we do that? Well, of course, it starts with a good extraction bone grafting technique. Those of us who follow me and have been to my lectures, we know that I love using a PTFE membrane, just really setting ourselves up to grow a large amount of attached tissue around which to place our implants. Sometimes patient presents to us that they have a little bit of bone resorption on the buccal. Sometimes the level or the amount of attached tissue is kind of minimal. And in these particular cases, instead of splitting the tissue right down the central groove in our partially edentulous extraction site, sometimes we'll sneak that incision slightly lingual or palatal to gain a little bit more attached tissue on the buccal there, being careful not to drop below in the sublingual area, which we don't want to be. The other way we can do is to get the amount of attached gingiva increased around our implants is to do some surgery. So here we recommend placing implants, letting the implants integrate for roughly about 2 months or so. Then in here we took a free palatal graft, and we just kind of let that heal for about 6 or 8 weeks. And then we go in and expose our implants secondarily and place our gingival formers or healing caps. And we develop a good amount of attached tissue, keratinized tissue on the buccal there. Let's set ourselves up for success. Okay, now let's get into periimplantitis. So periimplantitis, if you look at overall complication rates of all implants that are placed, the prevalence in the literature shows us anywhere from about 10 to almost 50%. Okay, and of course, the clinical presentation is edema, erythema, swelling, purulence, pain, bleeding upon probing. And the thing that really separates periimplantitis from peri-implant mucositis is bone loss. So here we have bone loss. Now we finally see radiographic bone loss. Okay, the key, as we said, to all complications is prevention. So what we do then is let's go proper diagnosis. Let's get proper implant position. Very, very, very important. Let's keep our restorative margins also, once again, in properly, easily cleansable areas for our patients. And think in terms of prior to implant placement, let's develop the proper phenotype that we have to deal with too, as well as the hard and soft tissues. Okay. Once again, too, let's choose implants with good macro and micro designs. Let's look at our patients that have come to us with high risk factors, patients that are smoking, patients that have periodontal disease in other parts of their mouth, patients that maybe present to us not in the best health. And let's think in terms of let's optimize those particular patients, those particular situations, once again, to put more eggs in our basket. Let's try to set ourselves and the patients up for success. Okay, so now, once again, now we know the definition between periodontal health, mucositis, and implantitis. And based upon this now, let's set up a classification system, which ultimately will be linked to how we're going to treat these particular situations. Okay, so Fromm set up this periimplantitis classification workflow system, which I think works out pretty well. And he separated periimplantitis into early cases, moderate cases, and advanced cases. So early cases, those cases are the ones that present to us with probing depths greater than 4 millimeters, and bone loss less than 25% around the total length of the implant. Moderate cases present to us with probing depth slightly bigger than, larger than 6 millimeters, and bone loss 25 to 50% of the total implant length. Advanced cases, here we see probing depths greater than 8 millimeters and bone loss around the implants of greater than 50% of the length of the implant. Okay, so early periimplantitis. Here, once again, probing depths greater than 4 millimeters, bone loss less than 25% of the implant. Treatment here. So here we find these early periimplantitis cases are typically related to some maybe plaque or cement accumulation underneath the tissues. So how do we treat that? We're going to do a closed debridement. We're going to get in there and curette around the implant. We'll do some irrigation, as we mentioned before, with mucositis. We'll irrigate with normal saline, PRF, fibrin exudate, chlorhexidine, sodium hypochlorite. In the literature, it shows us that not so important is what we irrigate with, but as long as we do irrigate out that sulcus. And then once again, if it is infected with some purulence, we're going to here use local antibiotics. In the initial treatment, as we said, intrasulcular injection of antibiotics, some exudate, kind of cleaning around. This is correctable. This is correctable. Okay, now moderate cases of periimplantitis. Here the patient presents to us with probing depths greater than 6 millimeters, bone loss of about 25 to 50% of the total implant length. Now, interesting, I was asked to do a lecture on periimplantitis, a symposium, about maybe about a year ago or so. And when I was preparing for the particular lecture, I did my literature search and stuff. I looked at a bunch of meta-analysis, systematic reviews, and it was very interesting. Most of the review articles that I looked at, most of the highly successful cases had 5 particular criteria that were associated with all the successes. Every single case that worked out very nicely recommended with moderate and advanced periimplantitis, they all shared 5 separate characteristics. Number 1, as far as treatment goes, they recommended a full thickness flap. Okay, it's very, very important. If you're going to treat periimplantitis effectively, you need to open up a full thickness flap. The second successful criteria that all of these particular articles showed is that once the flap is opened up, somehow you need to debride out that area, whether it's by hand instrumentation, as we talked about before, high-speed instrumentation, laser debridement, whatever it needs to be. Number 2 is that the area needs to be debrided out very, very well. Number 3, they all shared the characteristic of having a that they all tended to detoxify or decontaminate the implant surface. Some studies use citric acid, some studies use Paradex, some studies use sodium hypochlorite, number 3. Number 4, the high degree of success on these cases all showed a bone grafting material being placed afterwards. I'll show you what our particular protocol is in our practice, and then in addition to membranes. It was interesting too. Membranes were very important. PRF membranes were very, very good in helping to form and develop keratinized tissue. But even better than that was collagen or resorbable membranes around the implants. Interesting. And number 5, the patients that did very, very well, the 5th category was they were set up with a great home care system. Okay, so those are the 5 categories that everybody showed in common. It gave us the best degree of results. Okay, so here, the moderate case here, as we say, we're going to open up. This is a particular Straumann implant I placed about 20 years ago. And of course, on a referring doctor's wife. So she came in several years back, and she has some purulence in the sulcus there. So we opened it up, and we see that, of course, the cause is some cement. And of course, I said to my buddy, I said, oh, the cement is the cause here. I said, do you want me to tell your wife that was the cause? Because you can say anything you want. She hates me anyway, so it doesn't even matter. So of course, we debrided out the cement, and you can use curettage, you could use laser, you can use titanium brushes, you can use burrs, whatever it is we need to debride out the area. Okay, very, very important. Remove all the granulation and fibrous tissue. Okay, number 2, then we need to decontaminate the area. Okay, and there's different ways to decontaminate, as we mentioned before. In our practice, what we tend to do is we irrigate with Paradex and then apply citric acid, irrigate with Paradex, citric acid, irrigate again with Paradex and back to citric acid 3 times, and that's how we decontaminate the surface for moderate implantitis. Bone grafting. I like to use a xenograft with PRF. I like the xenograft in there because not necessarily are we going to expect to grow bone, but we want to just provide that a bulk of bone around that implant and provide a membrane on top of that to hopefully prevent the soft tissue from growing back around the implant. Okay, and once again, I like an amnion corium membrane because my feeling is that if the wound does tend to dehisce early on, the amnion corium membrane really helps form fibroblasts and epithelial cells really, really quickly, and we get a chance to cover up that wound really quickly. Okay, and then I like PRF on top of that, and that's how we treat moderate periimplantitis. And this is 3 years later, so it worked out pretty well. Now, advanced cases of periimplantitis, here the probing depths are greater than 8 millimeters and the bone loss is greater than 50% of the implant. Once again, the 5 characteristics that all those successful cases showed, we're going to do an open flap. We're going to mechanically debride the area. We're going to irrigate and detoxify that area. Then we're going to apply bone grafts, some membranes, and here we're going to consider maybe even apically positioning our flaps, removing the prosthesis. Once again, we always want to try to arrest the disease, stop the bone loss, and then get on with some good healing. If we gain bone, that's all the better. So here's a case. We did an all-on 5, all-on 4 restoration. You can see the patient presented there. I think the problem here for us is that we didn't develop enough attached tissue there. As we can see, patient presented with some bone loss there. We opened it up, open flap design, debrided it out, decontaminated with, as we said, citric acid and chlorhexidine back and forth about 3 times. And then here we did a xenograft with mineralized cortical cancellous bone and put some membranes around that as well. And this is the, let me go back again. This is the immediate post-op CBCT that we placed. You can see the bone that we added. And then this is our follow-up 5-month CBCT. We actually got some bone formation there too, which is nice. Okay, so we're finding that the bacteria that are involved with periimplantitis are the same bacteria that are involved with periodontal disease in the oral cavity. So it involves gram-negative anaerobic bacteria. So Rams did a study, and he found that because these are the bacteria that are causing these problems around the implants, that it's important maybe not for just single antibiotic treatment, but maybe a combination. And we recommend amoxicillin and metronidazole. Okay, you can go 500 milligrams each TID if you'd like. We typically place the patient on amoxicillin for about 7 days. Metronidazole we do about 4 or 5 days. Okay, now for those cases that present back to us with advanced refractory to treatment periimplantitis, these are the ones that we tried to treat it, the ones that had greater than 8 millimeters of probing depths. The bone loss around these implants were greater than 50% of the total length of the implant. You know, we tried to save the implants, but at this point, you know, we have to deem the implant as being an implant failure. Okay, it's interesting too. Let's go back to this slide for one more second too. It's funny because if we place this implant, if I place this, and I placed this implant came back to me and I see over 50% bone loss, I'm going to try to save that implant if I can. If this implant was sent to me and it was 20 or 30% bone loss around it by a competitor in my area, yeah, I have to recommend to take that implant out. Okay, so implant failure. Let's talk about implant failure. Okay, now, what we're going to talk about if we have time at the end of this particular part 2 webinar is that we really need to be very, very critical about the implants that we place. Okay, we need to be very critical about these implants. So this was an implant that was referred to us for treatment. I did not place this implant, but you can see over here, probably the cause might be prosthetic, right? Maybe the implant was placed a little bit too palatal and it created that huge ridge lap effect there. It's very, very hard for our patients to keep that clean. Another case that was referred to us for treatment here, this is a placement of these implants in teeth number 7 and 8 position here. Of course, immediately thinking iatrogenic here. Maybe there wasn't enough attached tissue. Maybe the implant was placed too far buccal. Maybe there was a thin buccal plate. Maybe this particular implant was a tissue level implant placed subosseous. Okay. Once again, we need to be very, very critical about why these particular cases failed. Okay, so here's another case that was presented to us, and you can see over here a high degree of recession around this implant, so much so this crown was replaced 3 times by a restorative doctor along the way. The implant was obviously placed too far buccal. Here's our cone beam scan upon initial presentation, and you can see that the buccal part of that implant is almost totally out of the bone there. Okay, so we placed this particular patient on our protocol for implant failure to remove the implant. Amoxicillin, we give 875 BID or 500 milligrams to stat 1 QID. We give them to about a week or so. Chlorhexidine rinses we place if there's any signs of purulence at that particular time of presentation. We like to recommend start antibiotics 2 days prior and continue for about 5 to 7 days post-op. Our treatment plan is to remove the implant, aggressively curette that socket, remove all that soft tissue, infected tissue in that area, get some good bleeding bone, because that's how we know implants, bone will heal, bone graft will heal, implants will heal in areas of good bleeding bone. Okay, and then we're going to bone graft the site. So here we're just going to use forceps. Just the implant will just tend to rock out exactly like you would think. This is one of those old Calcitech placed implants. What we'll do next is we're going to just aggressively curette out that socket, just get all that soft tissue out. And of course, you can see as we're aggressively curetting, there's probably no buccal plate there. We're just going to remove all that soft tissue from the socket. It tends to adhere pretty well. It tends to be very tenacious. So just gently kind of just want to remove it out there. Try not to tear the buccal flap in any way because we need as much soft tissue as possible when you do close these areas. Okay. We're going to establish some good bleeding points, get some good bleeding bone. And in this particular defect, we can see that there's buccal plate missing as well as palatal bone missing. The technique that I like to use when I have a buccal plate or a palatal or lingual plate missing, I like to try to restore that particular buccal plate or lingual plate with a resorbable membrane. So I'll place a resorbable membrane down the pouch that I create between the full thickness flap and the remaining part of the bone. And I'll do that on the buccal as well as on the palatal or the lingual. Okay, I'm kind of creating 2 new socket walls, so to speak, to pack my bone graft against. I like to use a PRF sticky bone, but here we can see that presentation there. And then what I like to do too is I like to use a non-resorbable PTFE membrane, and you can see some cytoplast sutures across the top here. And what I love about this particular technique is I'll bring the patient back weekly or biweekly, whatever it is, but at the end of 3 or 4 weeks, if the suture and membrane hasn't fallen out, I'll just gently take it out from the tissues here. When I remove the membrane, the tissue is going to look very red, inflamed, and ratty. And what happens is then is over the next month or 2, you get just this huge band of connective tissue, keratinized tissue that forms. So right over here from the level of the remaining connective tissue, keratinized tissue that's here, this whole area is just going to form a nice thick band of keratinized tissue. And that's going to be a great tissue that I can place around my implants as it heals. We always recommend overbulking these particular areas, the ones that are missing a buccal plate or palatal plate, because we always get resorption. And then we can go ahead and place our implants 3 or 4 or 5 months later. Okay, so that was iatrogenic causes, I showed an iatrogenic cause of an implant failure. The next thing we want to look at too is when a patient presents to us with an implant that fails is maybe there's systemic causes for the failure. So here's an article that shows us that a high LDL and a low vitamin D can be linked with implant failure. Okay, so now we know that a high LDL and low vitamin D are not good for bone metabolism. In fact, a low vitamin D slows bone metabolism and increases the risk for infection. Vitamin D, we're finding out in the literature, is very, very important. It's interesting because in the beginning of COVID, when COVID started about maybe 3 years ago or so, the patients that went into that were admitted to the hospital that came in with COVID that weren't intubated were the ones that had a good vitamin D level. Interesting. And vitamin D can also lead to high inflammatory levels and increase in osteoclast formation. We know the osteoclast tends to resorb bone. Okay, so we need levels for vitamin D over greater than 30 or so. Okay, we find is that if the patient presents to us with a greater level than 30, there's about a 2% chance of implant failure rate. 20 to 30, about a 4% early implant failure rate, and less than 10, about almost a 10% early failure rate. Okay, so vitamin D levels are very, very, very important. The next question I typically get, if you have a patient who comes in, do you normally test for vitamin D levels? Not routinely, because we know that most of the patients now in the Northeast where I practice, almost everybody is on vitamin D supplementation because we just don't get the sunlight that people say get in California or Florida. But if I do have a patient who presents to me maybe an ASA 3 or an ASA 4, or somebody who just doesn't look healthy, then yes, I will send them for a complete blood workup before we do implants and try to tune them up before we place implants. Okay, other causes for implant failure. Hot off the presses here, we have, this was a great study that was done, and they showed that when they looked at a retrospective study about implants placed, they found that patients had a higher failure rate who didn't have post-op antibiotics, pre-op or post-op antibiotics. Number 2, higher failure rates were noted in areas that were bone augmented, so bone augmentation procedures. Maybe you need to let those areas heal a little bit more before you place your implants. Implants who presented with early post-operative complications, those are the ones who tended to fail more than not. Implant diameters of less than 3.75 or shorter implants of less than 8.5 were also associated with higher degrees of early implant failure. Smoking. Smoking is an animal unto itself and very, very important. I always get this when I talk to patients, and I always say to them, listen, obviously if they come in smelling a smoke or if they have visual signs of heavy smoke usage, we kind of show them that statistically in the literature shows that you will have a higher failure rate. We encourage them to stop smoking, and it's very, very hard to get somebody who doesn't want to stop smoking. But we find is that smokers are associated with higher implant failure rates, maxilla greater than mandible, and also these particular patients are prone to peri-implantitis more so than not. Okay, so it's interesting because 2 goals we have with implant dentistry. Number 1, we want good initial stability, right? The implants are going to be able to fuse over time, but we want good initial mechanical implant stability. And we all know that curve that we're going to allude to, where you have mechanical stability is high upon initial placement, and then low is chemical bonds. And over a period of time, they tend to crisscross, and eventually the chemical bond takes over and the mechanical stability is not the most important part for osseointegration. So 2 things we need. 1 is initial stability, and number 2 is osseointegration. And we find is that smokers now have a decreased chance of secondary implant stability or osseointegration. And more importantly, we're finding too is that they tend to have early implant failures with immediate implants. Okay, so that's a discussion unto itself. Okay, so Michael Block had a great article that came out in the Journal of Oral Maxillofacial Surgery 2021. This is interesting. Porous bone in the mandibular, most importantly, mandibular posterior, can increase the risk of implant failure. So he's talking about the distance between the cortical bone and the implant that's placed. Okay, so if we look at that, we look at the space between the cortical bone and the implant was placed. If you had a cancellous space that was less than 4 millimeters, you had about 100% chance that that implant will be successful. If the space between your cortical bone and the buccal, say, of your implant that was placed as it was greater than 4 to 6 millimeters, there was about a 95% chance for implant success. If you had a cancellous space greater than of 6 to 8 millimeters, there was about almost a 90% chance that implant would work. So that was almost a 12% chance of failure. And if that cancellous space was greater than 8 millimeters, there was a chance for about 65% success rate. That left us with over a 35% chance of failure. Okay, so once again, you're just picking the proper size implant to be placed in the posterior mandible. Be very, very careful about that softer bone. Okay. Penicillin allergy. This is really, really interesting, I think, now, because now there's been some recent articles that show and are questioning now, do patients who present to us with a penicillin allergy, do they have a higher risk of implant failure? And a lot of the studies show yes. In this particular study, that showed that these patients who presented to this particular area, they were treated with clindamycin. And these particular patients, compared to a control, had almost 4 times the risk of a dental implant failure. So then what we do is we have to think is that, okay, so what makes penicillin allergic patients have a higher failure rate? Is it because of the penicillin allergy? Or is it because of the alternative antibiotics that we're using now? Could they cause a problem with integration? Okay, so this is another study done by Zara, and Zara showed us that when he compared implants placed on patients that had a non-penicillin allergy, he had about an 8.4% failure rate, but those patients who presented with a penicillin allergy had almost a 20% failure rate. It was interesting. In the patients who presented that had a penicillin allergy, those patients were treated postoperatively, given either clindamycin or zithromax. The patients that were given clindamycin had almost a 20% failure rate, while those patients that were given zithromax had almost over a 30% failure rate. And it was interesting, too, in his particular article, he showed penicillin allergic patients had a greater chance for early implant failure. Also followed up with French did a study and shows patients with penicillin allergy had a higher failure rate when you're looking in terms of immediate implant placement as well. Okay, so Fromm started to look into this a little bit more carefully, and he looked at the reasons for higher implant failures on patients who had penicillin allergies. And now, number one, maybe the reason for this. This is interesting. Maybe there was no association between that particular implant failure and the fact that the patient had an allergy to penicillin. And I would tend to agree with this particular statement because in May of 2021, American Dental Association came out with their position paper, and they said, okay, these are the patients now that we need to pre-medicate. No longer do we have to pre-medicate every single patient that presents to us with a heart murmur, and they went through the degrees of characteristics of those that do. But also at the end of the paper, they stressed that everybody who presents to you with a so-called penicillin allergy, we should recommend allergy testing, because 80 to 90% of those patients that presented to us and told us that they had a penicillin allergy did not have a penicillin allergy. So if a patient has a has an implant failure and they present to us with a penicillin allergy, but it wasn't really a penicillin allergy, that can't be the cause of an implant failure. So then Fromm followed up and said, well, let me look a little bit more carefully. Let me see if there is any degree of validity to these penicillin allergy patients. And what he found is that in a small percentage of patients, penicillin allergic patients do have a potential genetic variant in 2 human leukocyte antigens, and more particularly HLA-B. These particular patients have a higher acute and chronic inflammatory disease, which shows they can be associated risk for dental implant failure. Then the next thing we tend to look at is we need to look at the antibiotics that were given because the patient so-called had a penicillin allergy. And if you look at clindamycin, which has a high degree of failure as well, we find that clindamycin, it reduces the level or the activity of alkaline phosphatase, which is so important for bone healing. It also has an effect on osteoblasts, which also affects bone healing. So this might be the reason why patients who present to us with a so-called penicillin allergy have a higher failure rate. So this is something I think that's just coming out in the literature. It's definitely something very, very interesting. We should look at that in terms of that too. David, let's just do a couple more minutes, because then I do want to get to a couple more questions. So maybe we have to do a part 3 on dental implant complications, because there's so much more material that we have to cover. But let's talk about irradiated patients. And we found is that implants that are placed in patients who have been previously irradiated bone exhibited about a 2 to 3 times failure rate compared to non-irradiated bone. The key amount tends to be about 5,000 rads. We know that maxilla is greater than mandible. And then also in our literature, especially Bob Marks talks about this a lot with HBO therapy, hyperbaric oxygen therapy. And some people believe in this, some people don't. And this particular article shows that it did help craniofacial implants, but not as much dental implants. Okay. How about hypertension? A patient who presents to us with uncontrolled hypertension, does that have an effect on implant integration? No, it doesn't. It puts the patient at risk for stroke, heart failure, MIs. but no increase in implant failure rates. Interesting thing here, though, is that these patients who present to us that have uncontrolled hypertension, we refer them back to their physicians, hopefully again on some medication. But these antihypertensives are actually good for bone formation. Beta blockers inhibit those osteoclasts. We find thiazide diuretics also increase calcium absorption, and ACE inhibitors also function very, very well. We found that these antihypertensive medications increase our bone success when we do bone augmentation procedures, and also increase the overall survival rate of osseointegrated implants. Okay, so David, I think this is a nice place to stop. Next time, maybe we'll get into mechanical failures for late implant complications and late implant failures. And maybe we'll do some questions and for Q&A if you'd like.
Sure, I'd love to. Bart, great presentation. And you could probably have part 3, part 4, and part 5.
We would love to have you back on.
Yeah, but let's go ahead and do some Q&A. I think that would be great. And there are a lot of questions, all focusing in on the whole complication thing. And there's a question that one of the participants is asking regarding complications and allergies to dental implants, something that we didn't talk about today. But if you have some thoughts about that, I'm sure this individual would love to hear your comments.
Oh, sure, David. Thank you. Yes. So luckily enough, implant allergy is not that extreme when you're looking at overall implant complication rate. But it's very, very important, though, is that if you have a highly allergic patient that says they're allergic to all metals, they wear jewelry, they get inflamed, and all that stuff, you definitely want to get them allergy tested. You start by looking at your implant that you use. I know the particular implant that I use is made up of titanium, vanadium, and aluminum. So those are the metal factors that I would ask that patient to particularly get tested for. And that's how you start on that. Good question.
And I don't even know whether it's an allergy or a sensitivity, but we really only have 2 options. You're either going to make it out of a zirconia or a titanium implant. I don't know of a third today. Talk a little bit about, somebody asked a questions regarding your how to treat peri-implantitis that would probably be mild or moderate at most. How often does the initial therapy of scaling and irrigation solve the bleeding and inflammatory process?
Okay, yeah, good question. And it seems like it's a multi-layered question. So the first thing is that scaling and curettage is very, very good for those patients that present to us with mucositis. It's very, very good. So irrigation, what we'll do in our practice, we curette out the sulcus, we'll irrigate out with Paradex. We put them on a home care regimen, which involves Paradex as well. And we bring them back in about 3 or 4 weeks and we reevaluate the situation. So curettage usually works out very, very nicely if you catch the mucositis in the early stages. If mucositis tends to progress and we get bone loss, that's when we're now talking about peri-implantitis. So when we treat peri-implantitis, and you recommended a moderate or advanced case there, the first thing we always do, whether it's early, moderate, or advanced peri-implantitis, we put them through the same regimen that we would do to treat mucositis. So we'll do the curettage, we'll do the irrigation, and we reevaluate about 3 or 4 weeks after that, put them on an antibiotic if there's purulence. And after that, then at that point, we need to treat for moderate or advanced peri-implantitis.
Thank you very much. Another question about the abutment and what the abutment is made of. And this individual is asking, what's your opinion regarding zirconia abutments?
I don't do a zirconia abutment, so I wouldn't be able to comment on that at all.
Oh, okay, that's an easy one.
That was easy.
That's an easy one. And then someone is asking about autoimmune diseases. Placing socket bone grafts and dental implants in a patient with autoimmune diseases, even though they're on an antibiotic. How long do you like to wait after the socket graft is healed before placing an implant? And this is all in the context of someone that has an autoimmune disease. There was no specific autoimmune disease that was mentioned in the question.
Okay. Yeah, be careful with patients that have autoimmune diseases. That's important. So it's important to start with prevention, as we said. So talk to the doctors and see what the status is. Obviously, if they present to you, say, with maybe like a muconoid type of disease, maybe a pemphigus or pemphigoid type of disease, those particular patients, once again, tread very, very lightly because you don't want to be doing much work on them socket grafting wise because the tissue is very, very friable, and just be careful about that. The second thing is with autoimmune, be very careful about medications that they're taking too. Methotrexate in particular has a higher rate of implant failure. In those particular cases, what I'll do is I'll take the tooth out, I'll do a socket graft. I love doing PRF in my socket grafts with these particular patients. I find that they have a higher degree of success rate with the methotrexate. And I also recommend with autoimmune is stage the treatment. So maybe we take the tooth out and bone graft first, let that heal 3 or 4 months, 5 months or so, then place the implant. If it's really, really bad, then what we'll do is a 2-stage approach, expose the implant maybe about 3 or 4 months down the road. We just go very, very slowly with these particular patients. I would not do, major, take about 150 teeth out and put about 300 implants in at one time.
That is wise, and I think the questioner will appreciate your advice. Another question, and I'm not familiar with the product they're referencing: implant mucositis and/or perio-implantitis. Any thoughts on use of PerioFlow? I don't know what PerioFlow is.
I don't know either. I have no experience with that.
No, neither do I. I don't know whether it's a chlorhexidine. Can't help that individual. When you do these debridements and you flap them and you expose it, this participant is asking, will true integration develop after you place a bone graft around failed implants? Can you expect bone growth if horizontal bone loss is greater than 5 millimeters?
Right. No, you're not going to get true. We know nowadays you're not going to get true bone to implant growth again. Sometimes we do think we see it on an X-ray. We hope we see it on an X-ray, but the studies now show that you're not going to get that true bone to implant growth. But the whole purpose of doing the bone grafting, though, is once again, put something in that volume, that space that has been created through the bone loss to help prevent the soft tissue from growing around that implant again. So just set our patients up for good periodontal health.
And I think that makes sense. If not clindamycin, what would we use for penicillin allergy patients?
Yeah, that's always a tough one now because clindamycin has a higher failure rate, as we saw. Zithromax has been one that we've been using, but some studies are showing now that they're having higher rates. But mostly in our practice, we've been using Zithromax. The American Dental Association recommends now for prophylaxis for heart murmurs and valvular problems, they go amoxicillin. If somebody's allergic to that, they recommend doxycycline. But we've been using Zithromax in our practice.
Okay. Somebody took note about your double membrane technique, which, by the way, I utilize, and I agree with you 100% about the abundance keratinized tissue, attached tissue that gets formed. This question relates to that. In the case you remove the implant and you use non-resorbable membrane and resorbable membrane to augment the buccal and palatal plate, it doesn't require primary closure. So I assume it requires a high surgical skill to do this GBR without primary closure.
It's interesting. For people who are on the webinar, what I'd like them, if they want to try this particular procedure, which works really, really well, start with just a socket graft. Start with the cases that have a good 5-well defect, we say, just missing the occlusal part. Maybe the buccal plate is thinner than 2 millimeters because those cases are the ones we have to graft. Pack the socket and place this non-resorbable membrane underneath so that the 3-dimensional effect is that when we do this particular case, I'll lift up the tissue about 2 to 3 millimeters on the buccal and the palatal. I'll take that PTFE membrane, I'll kind of contour it. I sneak part of the flap underneath the flap of tissue, pack my socket and take the other PTFE part, and I tuck underneath my lingual flap. And then I do a figure 8 or reverse figure 8 suture over the top. It's such a simple procedure and it works out very, very well. As long as the patient keeps it clean, it works out very, very well. Start with those cases. And then once you get very comfortable doing that and it doesn't require that much more surgical skill, then you can go in and use this particular situation when you're trying to restore buccal or palatal plates.
And someone is also asking about, regarding complications, what is the sweet spot when it comes to torque values on implant insertion?
I think it's another good question. So what we want to do is when we place implants, we need that initial implant stability. That's so important. If you place an implant and it doesn't mechanically lock into the bone, it just tends to spin around, it's not going to work. It's not going to work. Just take it out. And if you can put a wider one and a longer one, of course, do so. If you can't, just regraft that socket and come back in about 3 or 4 months later. The next thing is when we place our implants, if we can place the implant and the implant doesn't move as we're placing the implant, it kind of gives us some good stability. Maybe it starts to move a little bit almost as it's down in the socket there. As long as I can get a cover screw in that implant, and when I place my cover screw, it doesn't spin with the cover screw, then I'm okay with that implant staying in place. And now I'll do a 2-stage. I'll cover it up and I'll revisit it about 3 or 4 months later to put on the gingival former or so. If I place the implant and the implant has an initial torque of 25 Newton centimeters or more, those are the ones that I'll place a gingival former on or a healing abutment on, and I'll do a 1-stage approach. And I let that integrate for about 3 or 4 months. If I place an implant and I get an initial torque greater than 35 Newton centimeters, those are the ones that I'll consider immediately loading.
And the age-old controversy, whether it's a controversy or not, is there a difference in implant successes based on whether the restoration is screw retained or cemented?
No. And the reason why I say no so confidently, if your cementation approach is if you have good technique when you do it, and there's proper ways of doing it, absolutely not. There should be no problem between screw retained and cementable restoration. Cementable restorations get a bad rap or have gotten a bad rap because a lot of times some doctors place the restoration and don't spend the adequate amount of time cleaning out the subgingival tissues there.
And I think we're going to call it quits there because there are pages of questions and you've answered them perfectly. And I want to thank you so much for being part of this web series, especially today. And we look forward to having you back again for part 3 of the trilogy. How's that?
That sounds fantastic. David, thank you so much. It was a lot of fun today with you. Thank you very much. Nicole, thank you.
Thank you so much
very
for being
welcome.
here today.
And I want to thank everybody. You know, next week, we'll see you back next week. And we'll have our good friend, Dr. Jack Hahn, who we all know. And his topic is going to be a little compelling. Implant placement in infected sockets. Is that safe? So we'll see you back here next week, same time. Dr. Park will be back. Have a great week. Good weekend to all.